Mohammad Nadeem Ahsan, and I am assistant professor and
सर
consultant.
थोड़ा loudly बोलें सर please.
यार जी, अस्सलाम वालेकुम. My name is Dr. Nadeem Ahsan, and I am a consultant nephrologist in Dow University of Health Sciences. Today we are going to discuss the chronic kidney disease. भाई ये कैसे आगे पीछे होगा? So today we are going to discuss the chronic kidney disease and what is the definition of chronic kidney disease and what investigation required to diagnose the chronic kidney disease and what complication you anticipate in kidney diseases and how will you manage the chronic kidney disease. So before we start the chronic kidney disease, different terminologies which are used while you are dealing with chronic kidney disease. So it's better to understand the different terminologies. And first is the azotemia, which means the elevated blood urea nitrogens and serum creatinine more than 1.5 gram. Uremia means the azotemia with sign symptoms of renal failure. So what are the sign symptoms of renal failure? It's vague symptoms. Patient may complaining of shortness of breath, easy fatigability, irritability, lack of concentration, poor appetite, poor sleep. So these are all are the signs, symptoms of the chronic renal failure. So what end stage renal disease means the uremia which required either the transplantation or patient may need dialysis. Chronic renal failure is defined as the irreversible kidney dysfunction with azotemia for more than 3 months. Creatinine clearance is the rate of filtration of creatinine by the kidney, and glomerular filtration rate, the rate of filtration of blood by the kidney. So what is the definition of chronic kidney disease? Kidney damage for more than, as we already discussed, the kidney damage for more than 3 months as defined by any structural or functional abnormalities of the kidney with or without decline in the glomerular filtration rate. So it's either manifest by pathological abnormalities or change in the kidney structure, including abnormalities in the composition of blood or urine or abnormality in the imaging test. Second thing is the GFR less than 16 ml per minute per 1.73 meter square for more than 3 months with or without kidney damage. So what is the marker of kidney damage? As we already discussed, the rise in the serum creatinine, urea, declining in the urine output or protein urea, or any abnormalities in the size, shape, and ecotexture of the kidney. Chronic kidney disease is defined as the kidney damage or glomerular filtration rate below 16 ml per minute per 1.73 meter square for more than 3 months. Irrespective of the cause, the Kidney Disease Outcome Quality Initiative guidelines have classified chronic kidney disease into 5 stages. As you see here, in stage 1, kidney damage with normal or increased GFR, and GFR is more than 90 ml per minute. And at this stage, we diagnose and treat the comorbids and slow progression, and also identify and treat the cardiovascular risk. In stage 2, the kidney damage with mild to decline in the glomerular filtration rate and GFR in between 60 to 89 ml per minute per 1.73 meter square. And at this stage, we estimate the progression of the disease. So how we will estimate the progression? We check periodically the serum creatinine, urea, and monitor the microalbumin urea in the urine, and every 6 months we check the ultrasonograph and to see the ecotexture and any parenchymal change in the kidney. In stage 3, moderate decline in the glomerular filtration rate and GFR in between 30 to 59 ml per minute per 1.73 meter square. At this stage, we evaluate and treat the complication like anemia, hyperphosphatemia, low bicarbonate, hyperkalemia. So in document the stage of the chronic kidney disease and treat the complication. In stage 4, severely decline in the GFR and GFR in between the 15 and 29 ml per minute per 1.73 meter square. At this stage, we start to prepare the patient for renal replacement therapy. In stage 5 or GFR less than 15 ml per minute per 1.73 meter square, and at this point, patient necessarily need renal replacement therapy in the form of either patient go to renal transplantation or maintenance hemodialysis. So true incidence and prevalence of the chronic kidney disease within a community are difficult to know, as the early to moderate CKD is usually asymptomatic. However, various epidemiological studies attempt to clarify this issue and have relatively similar observation, suggesting a prevalence of CKD around 10%, albuminuria, mostly microalbuminuria, around 7%, and GFR below 60 ml per 1.73 meter square is around 3%. So, if we think chronic kidney disease having the 10% in prevalence of CKD in our population, 7% is microalbuminuria and 3% in decline GFR less than 16 ml. So what are the chronic kidney disease risk factor? We classify into two different classes. One is the initiation factor and other is the disease progression factor. So in initiation factor, patient having the history of hypertension, diabetes, cardiovascular disease, or patient give history of dyslipidemia, or while you are checking the patient having the xanthelmas, uh, or patient having the high BMI and land into the obese class or metabolic syndrome. Hyperuricemia is also an initiation factor, and those patients who are smoked with diabetes or hypertension, this will a complex situation, and this will increase the risk of progression of the chronic kidney disease. Uh, in addition to the nephrotoxic drugs, NSAID, analgesics, or traditional herbal use or heavy metal exposure like leads. So progression factor, as the age of the patient is increased day by day, or so this is the risk factor to progress the chronic kidney disease. Certain male gender and Afro-American blacks are more prone to develop the chronic kidney disease. Poor blood pressure control, poor glycemic control, or proteinuria is also, if we are not properly controlling the blood pressure, sugar, or proteinuria, this will leads to the rapid progression of the chronic kidney disease. In addition, as we already discussed, dyslipidemia, obesity, hyperuricemia is also additional factor which deteriorate the kidney function. So this is the graphic presentation of the how the kidney damage occur and how the healing and fibrosis take place. Kidney cell tubular or glomerular are having the injury secondary to, as we already discussed, the poor glycemic control, blood pressure, hyperuricemia, or exposure to the NSAID or other analgesic or heavy metals exposure. So whatever the reason, kidney cell glomerular or tubular cell or damage. So cell transform and the reverse embryogenesis start, embryonic phenotype and myofibroblast proliferation and migration take place, and the production of extracellular matter production. So this will lead to the fibrosis and scarring. This myofibroblast recapitulated and embryogenesis and mature phenotypes, and this will lead to the healing and towards the normal kidney structure. So this is another figure which show the how the injury start. This is the endothelial cells, and whatever the reason, these endothelial cells are injured, and it will leak certain chemicals like cytokines and chemokines. These cytokines or chemokines, along with these cell adhesion molecules, it will aggregate and accommodate the platelet in the lumens, and this injury exceed, and this will also different chemical signaling will recruit the monocyte macrophages in this injured environment, and ultimately the activated mesangial cell which produce the extracellular matrix production. So by this, as we see, the monocyte influx, foam cell, and stretch epithelial cell, this normal size of epithelium is stretched, and it will injure, and loss of podocytes, food processes, so ultimately leads to the fibrosis, and this fibrosis is indicate the chronic kidney disease. So how will you investigate the patient of a chronic kidney disease? We start for the basic test, urea, creatinine, and electrolyte. You may find the high in the urea, blood urea, and serum creatinine, and sometime you may find hyperkalemia or hyponatremia, for calcium, or more or less on the normal or less below the normal level, with phosphate on the higher side. Uric acid may be high, magnesium low, and albumin depend on the dietary status of the patient. Urinary analysis will tell you the presence of proteinuria, hematuria, or RBCs, or red cell cast, or other positive finding you may find in the urine DR examination. And we quantification of the protein in urine, or on the bedside we used to do the protein to creatinine ratio. Complete blood count will tell you the exactly the micro microcytic microchromic uh, anemia with the normal platelet and normal WBC. And in a special situation, we do the anti-nuclear antibody tests, yeah, ANCA test, and we also require 24-hour urinary protein and creatinine clearance. And in late stages of chronic kidney disease, as a stage 3 or 4, we check the parathyroid hormone and iron profile. And in certain situation, when you having the set chronic kidney disease stages, suppose patient having the second stage chronic kidney disease, and you may find the sudden rise in the serum creatinine, or a suddenly increase in the protein urea. So you are not expect the usual course of chronic kidney disease, and you may your clinical suspicious is to having the some other problem other than the chronic kidney disease. At that time, you if the all the lab are suggestive, then you plan for renal biopsy. Acha, radiographic evaluation, we do in a normal situation renal ultrasound that will tell you the any obstruction, any stone or tumor, and it will tell you the size of the kidney, shape of the kidney, and any chronic change in the parenchyma. A duplex ultrasound will tell you the renal artery stenosis, or normal flow or decreased flow to the renal artery. Bone evaluation will tell you this. It's basically a situation of secondary hyperparathyroidism that will lead to the osteoporosis and bone fracture, and some patient will require parathyroidectomy to help to prevent this problem. So this is the normal image of the kidney, and this is the ultrasonographic image of the normal kidney. You can check the length of the kidney, that is around 10 to 12 centimeter, width of the kidney which is around 4 to 6 centimeter, and parenchyma which is the glomes of the kidney, that is the functional part of the kidney. So if you are look at the outer margin of the kidney, and this is the inner capsule of the kidney. So this, you may easily identify this darker external portion with the some extent a lighter or whitish structure inside the kidney. This is the cortex, and this area is medulla. This is the normal ecotexture of the kidney, and you can easily recognize the outer cortex, differentiate between the outer cortex and the inner medulla. And here you cannot recognize between the cortex and the medulla, and all the kidney structure are sclerose and fibrose, and you cannot differentiate between the cortex, where is the boundary of the cortex, and where is the medulla. So all the structure look like same. So this is the classical picture of chronic kidney disease. So when to refer the patient to a nephrologist? All newly diagnosed patient with having the estimated GFR less than 30 ml per minute per 1.73 meter square, or the hemoglobin less than 11 gram per deciliter, or serum potassium for more than 6 millimole per liter, low calcium or high phosphate, or parathyroid hormone more than 3 times from the normal upper limit, or patient at any stage present to you with hematuria. So these are the indication to refer the patient to a nephrologist. Uh, in stage 3, if the estimated GFR falling by more than 4 ml per minute per year, or the GFR less than 15 ml in a patient younger than 50 years of age, if the hemoglobin, as already discussed, less than 11, high potassium, low calcium or high phosphate. In stage 3, if any general practitioner or physician may find these vital things in the patient, and this is the time to refer the patient to a nephrologist to treat properly. And in stage 3, more or less are the same: hyperkalemia, low calcium, phosphate or a PTH on the higher side, or GFR decline more than 4 ml per minute per year. So how will you manage the complication of chronic kidney disease? So most common uh, complication is anemia in stage 3 to 5 of chronic kidney disease stages. It is caused by relative deficiency of erythropoietin, although reduced availability of the iron and chronic inflammation are frequently contributory factor. Anemia may contribute to cardiac dysfunction. Anemia in adult is diagnosed when the hemoglobin concentration fall below 12 gram per deciliter in men and below 11 gram per deciliter in women. So anemia is almost universal complication of chronic kidney disease. It contribute considerably reduce the quality of life of patients with chronic kidney disease and has been associated with number of adverse clinical outcome. So what is the pathogenesis of renal anemia? Anemia is typically is isolated normochromic normocytic anemia with no leukopenia or thrombocytopenia. Both the red cell lifespan and the rate of production are reduced, but the latter is more important. So lifespan is also affect having the impact on the anemia, but because of the deficiency of the erythropoietin, uh, red cell production is impaired in chronic kidney disease. APO is normally produced by the interstitial fibroblast in the renal cortex, and APO stimulate the red cell production through the binding to the hemodimeric APO receptor, which are primarily located on the early erythroid progenitor cells. So if you are correcting the anemia, so these you can prevent these adverse effect on cardiovascular system. It will, if you are correcting, it will reduction in the high cardiac output failure, reduce in the stroke volume output, decline uh, in the patient heart rate, increase peripheral vascular resistance, so you can easily manage the patient blood pressure, decrease the anginal episode, and myocardial ischemia, regression of the left ventricular hypertrophy, and stabilization of the left ventricular dilatation. Other secondary effect while you are correcting the anemia or reduce blood transfusion, increase quality of life, increase exercise capacity, improve cognitive function, improve sleep pattern, improve immune function, muscle function, and also patient out of depression, improve nutritions, and it will improve the platelet function as well. So how will you start to give the erythropoietin? Basically, it's half-life of 6 to 8 hours, and we are giving intravenously or subcutaneously with the usual dose of 20 to 50 international unit per kg twice or thrice a week, depend on the severity of the anemia. And if you are giving the erythropoietin, still patient having the poor response to develop the hemoglobin, so these are the major and minor factor which affect the erythropoietin response on the bone marrow. If the patient having the iron deficiency, or patient having the infection, inflammation, or those patient who need dialysis but they do not dialyze properly, eh, less minor is the patient not taking medicine properly, or a patient takes sometimes and sometimes miss the dose of the erythropoietin, or any history of blood loss in the form of hemorrhoids, or loss of secondary blood from the GI loss, or so other substance which we check is the vitamin B12, folate, or we also consider the other hemoglobinopathy like sickle cell disease, or those patients who are on ACE inhibitor or angiotensin receptor blocker also develop the resistance to erythropoietin, and having this less response to produce the hemoglobin. So bone and mineral metabolism, hyperphosphatemia together with the deficiency of 125 hydroxy vitamin D3 contribute to secondary hyperparathyroidism and ultimately to the development of renal bone disease. Metabolic acidosis associated with loss of hydrogen ion excretion and may be compounded by bicarbonate loss. So in CKD, patient retaining the hydrogen ion and excreting the bicarbonate through kidneys. Sodium handling by the kidney is altered in chronic kidney disease, so we are restrict the sodium intake 2.4 gram in 24 hour, and by this we are also controlling the blood pressure. Hyperkalemia is a very life-threatening condition in chronic kidney disease patient, especially in the stage 4 and stage 5. And we manage the hyperkalemia by the dietary restriction less than 60 millimole potassium per day. So this is the ECG presentation of the normal person with having the normal P wave, PR interval, Q wave, T wave. This is the normal ECG rhythm of a normal person. While you check the serum potassium, if it's on the higher side, it will increase the T wave, and as the number of potassium increasing, the change in the shape of the T wave, also the change in the QRS complexes. While you reach 8 to 9 millimole per liter, you cannot recognize the ECG. It's a Bezier type of electrical activities, and this will lead to the atrial stand still or sun wave type pattern. So patient may goes to the cardiac arrest or heart block or sudden arrhythmias, ventricular arrhythmia or atrial arrhythmia if patient having the hyperkalemia in CKD patient. So how will you treat the hyperkalemia? You antagonize the membrane effect by giving the calcium, and it will having this rapid onset It will start within the 1 to 3 minutes, and it will last for 30 to 60 minutes. Cellular potassium active through insulin and beta adrenergic agonist. We give the IV insulin with 50% dextrose, and its effect start within 30 minutes, and it will last for 4 to 6 hours. Basically, it will displace the serum potassium to inside the cell and give you certain time to do the ultimate uh, removal of the potassium from the body. And potassium brings sodium polystyrene sulfonate are the potassium binder. We give the 60 gram or 30 gram, depends on the serum potassium level, and along with juices or sorbitol, and it effect start within 1 to 2 hours and last for 6 to 8 hours. And ultimately, if the hyperkalemia is not respond to these above therapy, we plan to do the hemodialysis to remove the extra potassium from the body. Insulin clearance is decreased in CKD patient, and with the increased peripheral resistance, uh, as a result, there is usually no clinical manifestation, and the patient are not particularly prone to the hypoglycemia. Patient with diabetes may lead to falling requirement of the insulin as kidney function decline. So uremic syndrome. What is this uremic syndrome? It's as we already discussed, the sign symptom of azotemia and fever, malaise, anorexia, nausea, mild neuronal dysfunction, or uremic pruritus. If these features are present, we label it as a uremic syndrome, and this uremic syndrome may require dialysis. This is the brownish hyperpigmentation in the sun exposed area. This is present in dialysis population patient. This is the scratch mark, uh, and you may find the rough and dry skin, and this is also present in dialysis patient, and we label it as a xerosis. This is a very classical sign in CKD patient. Usually the base of the nail are pink and the terminal portion are the white. But in this CKD, we are label it as a half and half nail. So the proximal portion become whiter and the distal portion is more redder than the proximal portion. And this is the classically present in chronic kidney disease patient, especially in the fifth stage or those patients who are on dialysis. So this is the management plan. As we already discussed, in stage 3, GFR in between the 30 to 59, and uh, patient having the hypertension, secondary hyperparathyroidism, and you can check the hemoglobin, potassium, calcium, phosphate, and treat the hypertension, and vaccinate against the influenza and hepatitis B. In stage 4, the GFR in between to 15 to 13, and a patient creatinine is around 4 milligram per deciliter, and plus patient having the anemia and hyperphosphatemia. 3 monthly GFR are assessed, and 6 monthly if they're stable, and check the hemoglobin, potassium, calcium, phosphate, and parathyroid 6 monthly. Basically, in our population, we check the hemoglobin, potassium, calcium, and phosphate on third month. Every 3 months, if it is stabilized, then we go for 6 monthly, and we check the parathyroid hormone 6 months. Correct vitamin D deficiency, start vitamin D analogs, plan for renal replacement therapy including vascular access. And in stage 5, if the GFR less than 15 ml per minute per 1.7, and you may find the serum creatinine around 6 to 8 milligram per deciliter. At this stage, we restrict the sodium, water, and patient having the anorexia, vomiting, reduce higher mental function. So plan for elective uh, start of the dialysis or preemptive renal transplant. If the GFR fall from below the 5 ml, you may find the serum creatinine more than 12 or 15 or 20, and patient may present with to you with history of severe shortness of breath, and you diagnosed as a patient having the pulmonary edema. Patient also present with fits or severe metabolic acidosis or hyperkalemia, and this is a very grave situation. This is the medical emergency, and we start dialysis, and also all the other palliative cares. So we give vaccination in CKD patients uh, for hepatitis B virus and also influenza virus and pneumococcal vaccine. So hepatitis B vaccination is recommended for all the pre-dialysis and dialysis patient, but the seroconversion rate uh, is not adequate, and patient may require double dose of vaccination. So usually we use the 20 microgram sub-Q at the 0, 1 and 4th week, and checking the anti-hepatitis B surface antibodies, and if it is more than 100 international unit, it's a good response and patient having the protection. But if the anti-hepatitis B antibody is less than 100 international unit per liter, then we give third dose of vaccination after 8th week of first last dose. And again we check the hepatitis B surface antibodies. If it is more than 100, then it will okay. If it's still a patient having the antibodies level less than 100 international unit per liter, give fourth dose of the vaccination. And if it is still less than 100, we label it as a non-responder. A preparation of the renal replacement therapy at the GFR of less than 15 ml per minute, or in late stages of 4 or early stages of stage 5, patient receive education and counseling to guide their selection of the most appropriate renal replacement modality. If hemodialysis is preferred option, an arterial AV fistula should be constructed, remembering that it may take 6 to 8 weeks for the vein to become adequate arterialized before needling can be attempted, because early kidney transplantation improve long-term outcome. So how we start the blood dialysis? Basically, dialysis is the process in which the tube, which is dialyzer, we call dialyzer, having the parallel chamber or layer of the parallel layer compartment, in which one compartment having the blood flow on in a one direction and dialysate flow on the other direction, and uh, dialysate containing those substance which is required by the body, means dialysate contain high bicarbonate, and in between two compartment having the semi-permeable membrane, the unwanted substance from the blood is goes to the semi-permeable membrane into the dialysate compartment, and the those which is required for the body is shift from the dialysate compartment towards the blood compartment. So end of the day, you lost the urea, creatinine and other nitrogenic waste product in the dialysate fluid, and hydrogen ion also, and you can transfer bicarbonate or other calcium or other essential substance which is required by the body, which transfer from the dialysate fluid towards the blood. Thank you very much. हेलो, एनीवन वांट टू आस्क एनी क्वेश्चन? देखो इसमें कोई क्वेश्चन कैसे देखने हैं मुझे?
वालेकुम।
वालेकुम सलाम। ये क्वेश्चन एक ही था मैंने।
क्लास आपकी एंड हो गई क्या?
हाँ मेरी क्लास तो खत्म हो गई।
ठीक है, तो अभी क्वेश्चनरी चल रहा है।
एक ही क्वेश्चन था, मैंने दे दिया। अब कोई और रिस्पॉन्ड तो नहीं आ रहा, 5 मिनट वेट कर लेते हैं।
ठीक है, ओके ओके।